We're going to talk about community-acquired MRSA. 4 years ago, this didn't exist. I mean, I wouldn't have been up here talking to you about this. It's the spider bite syndrome. All of a sudden, we had 8 billion people showing up in the emergency department with spider bites at triage. And how about you in your offices? You guys seen? Who has not seen a case of community-acquired MRSA? Is this amazing? This is amazing. I think I did my internal medicine training in the early 1980s, mid-1980s, in San Francisco. We saw a new, nasty, horrible infectious disease then, which was HIV. It was HTLV3 then, now it's HIV. But we saw a rapidly emerging, really deadly disease. We are seeing a rapidly emerging, not yet, but maybe becoming, deadly disease. This is an incredible thing. This did not exist 4 years ago. MRSA, until 3 or 4 years ago, was the nursing home patient with the 50,000 decubitus who came in and everyone freaked out and put on their gloves and their masks and their gowns and put them in some little room because God forbid you didn't want that MRSA. That was bad MRSA, hard to eradicate, terrible stuff. Historically, as we go through this, what we're going to talk about is who gets it, how do they present, and what do we do about it? Sort of what we're going to talk about right now. And that if you kind of go historically, where this first was described, it was in 1999. If you really want to see the first of anything, the first toxic shock case, the first HIV case, the first MRSA, community-acquired MRSA case, go to the MMWR. That's where most of this first stuff showed up. By the way, I'm the second described case of toxic shock syndrome in this country. Thank you very much. I was in MRSA back in the MMWR way back when. The first ever episodes of things are always in the MMWR. And in 1999, they reported 4 cases of pediatric deaths from MRSA that it was absolutely unclear where these kids got it. Okay, 4 cases, 4 kids died. There were North Dakota and Minnesota. I was like, where did this come from? And then it kind of like just dribbled away. 4 years later, what they did in the MMWR as well is they reported on the competitive sports thing. This was, wow, we're seeing these weird little spider bite things in the wrestlers, the high school wrestlers, the competitive sports kids, usually high school sports. They were described that in 4 different states, 4 different areas. LA, I guess you'd call LA a state these days, Pennsylvania, Indiana, and Colorado. It was like, okay, wait, it's kind of all over geographically, and we're seeing these weird things in young competitive athletes. And when they get cultured, it's MRSA. Now, how weird is this? What is the deal? Where did it escaped the nursing homes? And what's the story? What happened? There's a paper in there, it's an implicit chart review, I believe it's Ayer's paper, that looked at 39 patients at UCLA in a private dermatology practice that was affiliated with UCLA. And they noticed in this practice that they had 39 cases out of the blue of MRSA. Now, of the 39 cases, 20 were HIV positive patients. It's like, well, maybe that's some new thing that HIV positive patients are getting, but 19 of them were walking, talking, normal, you and me kind of people. It's like, what the heck is going on here? This is the west side. We don't allow icky, horrible things on the west side of LA. You have a Beamer. You don't get horrible things. It was like, what is the deal? What's the problem here? Where's this coming from? 2003, they had a study from Minnesota that reported 131 community-acquired cases. And what they did in that study is they compared them to the patients that got the health care facility-associated MRSA. What was different about these 2 populations? What's the nursing home presentation and who gets that versus this community-acquired thing? And it's young, healthy, it's you and me that were walking in with MRSA. It's like, what is the deal? The abstract by Frizzy in there, the UCSF paper, by the way, a little asterisk, for those of you that are emergency medicine docs, again, this is in the 2007 LLSA articles. The new list just came out. This one's in it. So this Frizzy paper, you're going to need to know, inside out and backwards. This one reported on a convenient sample of 137 patients at UCSF that they saw with MRSA. What they found is that, and what they did here that was interesting, is they cultured the nares as well. One of the things that was brought up as an idea is maybe people are getting this in their nose, they're carrying it around, and then are either inoculating themselves or other people. It's a mode of transmitting this to other people. What they did in that paper is they cultured the nares of everyone, and then they cultured the sites, if possible, of where the actual MRSA infection was. What they found is that 51% of the sites themselves grew MRSA. 20% of the patients across the board, their nares also grew it. They may not even have had anything on the periphery. And 76% of the cases were community acquired. Okay, so it was a big deal. We'll come back to more in this paper. But overall, who gets it? Well, nowadays, it's healthy, walking, talking, you and me kind of people. Okay? Anyone can walk into the emergency department or into your office with MRSA. Anybody can. We had a whole family the other day that had it, where mom came in and she had a spider bite. She said, you know, it's so weird because my husband had a spider bite and our kid who sleeps with us in bed had a spider bite. There must be spiders in the bed. So they were all passing MRSA all around that family. They had passed it to everybody in the family. So MRSA is anybody and everybody these days. Now the thing about the MRSA, that when they present almost exclusively until recently with skin and soft tissue infections. That's the next section of this. What they come in with, that UCLA dermatology practice, what they found, the people there presented with cutaneous abscesses about 70% of the time. Now, at least initially, they tended to be little. They tended to be small, little cutaneous abscesses. They weren't humongo abscesses. They tended to be small, localized, with minimal cellulitis around it. And in fact, if you had that, especially if you had more than one, Frazie's paper says that is a very high likelihood of community-acquired MRSA. You come in with a small furuncle, especially if you have a small furuncle with another satellite one somewhere else on the body, the likelihood of that being MRSA is 76%. Okay, it's community-acquired MRSA. So you have somebody who walks into your office and has one right here that's maturing just fine, ready to go, and another little one down there, it's MRSA. Okay, it's MRSA. Kind of scary stuff. Much more likelihood to be MRSA. Now these days, one of the things that came up, we'll talk about serious problems with MRSA, and up until recently, it tended to be just skin and soft tissue infections that were kind of a little bit hard to treat. It's getting a bit of an attitude, and we'll talk about what's happening that's changing out there, but it's a bit of a problem. The treatment of this is actually relatively easy right now. One of the things that's interesting is the MRSA that you get in a nursing home is its spectrum, as far as its resistance pattern, is vastly different than the MRSA you get in the community. When they've done resistance patterns and susceptibility studies on the MRSA that you and I get, just from walking, talking, and getting sneezed on by somebody who has it, has a different spectrum of susceptibility. There are a bunch of papers in there. The Iyer paper's in there. The Frazee paper, the one we all have to know for our boards in emergency medicine, is in there. There's a paper by Naimi. The thing to know that's a bottom line is beta-lactams don't work, period. Up until now, if you saw somebody with a cellulitis or an abscess, you often would grab a beta-lactam as your first drug. If you have that person with a nice little mature little abscess and another little spot over here, don't grab a beta-lactam. It's not going to work. Okay? It doesn't work. What does work is Bactrim, rifampin, Klinda, Vanco, Linezolid. What's recommended for most people, if you're in an area where MRSA is now prevalent, and I'll tell you, if you are not in an area where it's prevalent, it's coming. Okay, it's just boomed. It's absolutely incredible. This thing has just exploded. If you're in an area where it's not common to see true MRSA, you can go ahead and use beta-lactams if you see a skin infection. But please culture. We went from no MRSA cases to 80% MRSA cases in 3 months. We cultured people, and we went from nothing to 80% of them in 3 months. Now it's virtually MRSA across the board when people come in with this stuff. It's just amazing. So if you don't have it yet, one case is going to take off. It'll be everywhere. So the treatment basically overall that's recommended, and there's a paper in here by Moran that's number, hang on, I think it's 7. It's a commentary that gives you an approach to probably what you should do with a MRSA case. It's an editorial paper by Moran, who's an ID and emergency medicine board certified guy. What he recommends is, if somebody comes in with an abscess from MRSA, IND it, okay, open it up and get the pus out. His recommendation is maybe not use antibiotics. I have to tell you, in our practice, and I work in a county hospital, absolutely, but this has been the same problem in our community locally. You need to use antibiotics to eradicate. What we found is that we were INDing abscesses in people, and they would come back with another one, and then come back with another one, and then another one. So it turned out that the abscess, yes, you can drain that abscess, but they have, either it's in their nares or they inoculate themselves some other way, but they come back with multiple infections, multiple abscesses. In fact, there are some people that have needed PICC lines with long-term care to eradicate it completely. What's really recommended is IND it and treat. How should you treat? You have several options. But the best recommended current regimen, and this is going to change, I think, eventually, but is Bactrim plus rifampin. The reason is Bactrim will take care of the local infection. It will not take care of that 20% of people that seem to have it in their nares. The rifampin is necessary to eradicate it from the nares. So Bactrim and rifampin are needed together. You can use Klinda as an alternative. I'm going to tell you two things about Klinda. It is very poorly tolerated orally. People do not tolerate taking a course of Klinda. And for some reason, this particular MRSA develops a rapid resistance to Klinda. We were able to use Klinda in LA County for about 6 months, and now we can't. Our resistance to Klinda has skyrocketed. It's 80%. We can't use it anymore. So we cannot use it at all. The other thing to know is quinolones, which are often indicated for skin infections, have variable resistance patterns depending where you live. Anywhere from some areas, you can treat it with fluoroquinolones, and some areas you can't. Only 64% are sensitive. So find out your own pattern where you live. The quinolone resistance is extraordinarily variable across the country. But the sensitivity so far to Bactrim and rifampin is fabulous across the country. We're good. There is a paper in there that looks at using Linezolid. Should you be using this oral, very expensive agent? Does it work? The answer is yes, but the paper that addresses it in here compares it to IV Vanco in a very seriously ill group of patients who needed surgical debridement of skin, community-acquired skin MRSA infections, like OR kind of stuff. They compared Linezolid to IV Vanco, and they found Linezolid was better. Those of you that work in an office-based practice where you may be taking care of these people in the hospital, and they are not responding to IV meds, particularly Vanco, consider using oral Linezolid. It may work better. But for those of us that are up front, you're dealing with just the person sitting in your office or sitting in your ER, open the wound if it's an abscess, go ahead and treat them with Bactrim and rifampin, and you're on your way. The other thing to know is we are now seeing something in LA where they're getting a super infection with strep. So they're now getting the initial MRSA. That MRSA now has a strep cellulitis around it, and what we're having to do is add back a beta-lactam to the patient because the cellulitis is not going away with just the Bactrim and rifampin. So be aware if you have a gnarly cellulitis with it that you may need to add back, in addition to your MRSA coverage, add back a beta-lactam. This thing is evolving so quickly the papers can't keep up with it. Yeah, they just can't keep up. It's kind of scary. What's your guys' experience with this? It's a good question. We started out with a 5-day course. We've gone to a 10-day course because we had so many treatment failures as far as how long. It's recommended 5 to 7, but they need follow-up, and we had a significant proportion of people fail. So we've gone to a 10-day course. Yeah.
Your local resistance patterns indicate that quinolones are an option. Do you have to add rifampin to that also?
Good question. I don't think we know if the quinolones eradicate the nares or not. I'm not aware of that. I'll have to look that up. I'm not aware of it. Our current, locally, we can't use quinolones, but our ID folks are recommending rifampin in everybody, regardless of what your primary treatment is, because they want to eradicate the carriage rate, and they know rifampin does it. So, yeah?
In our area, our actual ID docs, they're saying, you know, the antibiotics plus minus, their big thing is hibiclins. They say everyone should bathe in hibiclins, I mean, scrub really good.
Uh-huh. Right. There's a couple of things that are sort of the local lore that probably works stuff. For instance, in LA, what we did for a while, which some people are still doing, is use Bactroban in the nose. Anybody who is around, in fact, a lot of healthcare workers were getting a little bit of a vestibulitis, just a little bit of irritation around the nose, that they were carriers. So we're recommending using Bactroban around the nose. And hibiclins, there's actually, the last article on this looks at how to keep from getting this yourself. On how to, hibiclins actually does work to eradicate the bug on the skin, but you need to, it's not just a one-time deal. You need to actually wash for a while with the hibiclins. We'll get to that sort of in the end as well. Yeah?
We're actually from Alaska, and we've been seeing it since 1999. It started at Bethel, and it was the bad Bethel boils. And
The Bad Bethel Boils of Alaska.
Yeah.
It sounds like a singing group.
And you could see a boil like anywhere, like all the rest, unless they were from the Bethel area, and then you had to kind of do the Bethel boil rules. And what we initially did.
So you guys started it up in Alaska in 1999.
And actually, CDC studied it, and what they came up with was there's a problem with antibiotic overuse, anyways, in the villages. So the rule was if you see a boil, you drain it. If it was greater than 10 centimeters,
we had that too.
You had an antibiotic. It was Bactrim and rifampin sensitive, but they actually had us say rifampin. And so you didn't start antibiotics routinely ever unless you got to 10 centimeters. And they had kind of discouraged us from using rifampin.
Right. I think that the goal initially, when when it was a potentially containable disease, where we could try to keep it somewhere, that we had the same thing initially. You know, IND it, if it's less than 10 centimeters, don't treat them, watch them. But then we had huge patient, influx of just, because it's not a small, village area. We have the village of Los Angeles, which is, enormous. Yeah, I mean, I don't know. But I think the problem we have is I think the horse is out of the barn at this point. I think that we're stuck. But I think it was a laudable effort to try to not, increase the resistance pattern by having everyone get antibiotics. But boy, I'll tell you. And now I'll tell you, I think we're running into the problem that we could have predicted with a lot of antibiotics being used and this becoming a common infection, which is the bad things. There's a paper in there. Can you get a more serious infection from this, like necrotizing fasciitis? Abstract number 8 is from our institution, Harbor-UCLA. The data says there are 500 cases of necrotizing fasciitis in the country annually. I think we see them all at Harbor. Seriously. This is 48 cases of neck fash that we saw in 15 months at Harbor. We diagnose it once a week, twice a month. I mean, we see it all the time. We see neck fash. It's just like routine. All of us know how to recognize it. What they found in this study, they took 15 months worth of neck fash cases. There were 48 of them. Of them, 14 turned out to be from MRSA. And of those, 4 patients had no reason to have MRSA. Okay, they were just you and me walking, talking, came down with a MRSA infection and got neck fash from it. The other thing they found in that particular neck fash group versus the truly Clostridium type or the true the synergistic bacteria type of neck fash where they crash and burn in front of you, they evolve in front of you. These people with the community-acquired MRSA fooled us. They came in with a gnarly big abscess that we thought was just a gnarly big abscess that needed to go to the OR to be drained, and then they got in there and they found myonecrosis. And they found entire legs that had to be debrided. So this is actually starting to change its infection pattern. This went through 2004, April of 2004. And then the other thing that was mentioned yesterday, and I actually looked this up on the web yesterday, how many of you have seen a case of MRSA pneumonia, community-acquired MRSA pneumonia in the last couple months? I have. You guys have. Okay, you're Alaska. Where are you guys from? Washington, California. Where are you from? Indiana. Was another? Minnesota? Maybe it's trickling from the top. I don't. Because we've seen it as well. Community-acquired MRSA pneumonia is a fulminant, devastating infection of the young that's lethal. They have a fever, cough, shortness of breath. They look like the influenza elderly person who gets the Staph aureus pneumonia and crashes and burns. They look like that. They come in, they go into ARDS, they go into respiratory failure, you intubate them, they get septic, and they die. Like that. And the cases that we've seen, they've gotten a lot of peripheral vasoconstriction to the point of like losing, their noses get cyanotic, their fingertips.
Ours have all died within 10 hours.
Yeah, ours were 2. They were all 25-year-old, 12-year-old.
Vital signs, and neither of them had a fever.
They just crashed and burned that fast. Oh my God. This is scary, you guys. This is scary. This is the, forget avian flu, this is scary stuff. I think what we're seeing is a disease that didn't exist in the general population that now, as of 2003, was absolutely in the general population that's now expanding from skin to other parts of the body. And we're going to have to see what happens. I went on the web yesterday, because this was brought up as a question yesterday. I went on the web last night to see if there's anything, even in the MMWR, the CDC, or they have the surveillance system. There's nothing out there yet. But I think this is next year we're going to talk about emerging horrible infections, and I think we're going to be talking about community-acquired MRSA pneumonia. It's really scary stuff. So, any questions on MRSA? Yeah.
Did any of those people with the pneumonias have previous history of MRSA skin infections?
Oh, one of ours did. The other one, we didn't ever track it down. So.
One of them questionable, the other one, no.
Ours didn't have any.
Nothing?
Did any of them live?
Did yours live? No. Ours didn't. And were they young? Yeah, ours were young. 32. Yeah, we had a 12-year-old and a 20-some. Yeah.
Regarding the skin infections, given the example you had of the family where everybody kind of had it, do you recommend, considering that it seems to be getting worse and worse, that when people come in and you culture them and they're positive, that we culture their family members? Is this like a...
Probably better than doing that. Right, because at this point we're going to have to go out the waiting room and say, okay, everybody, come here. Let's smear you down. Probably the better thing to do is something like the Hibiclens. Something like sending them home with, yeah. The other thing for us to know, by the way, is this is something that we get. as healthcare providers. Be very careful with your skin care of yourself and your sort of precautions with people. In the old days, I mean, we always joke about dermatologists, they examine like this. There's a reason they do, because back in the old days, dermatology used to be, the Journal of Dermatology used to be called the Journal of Dermatology and Syphilology. You didn't want to touch it. Seriously, I'm not kidding, it was. So they don't touch things. You shouldn't touch rashes, okay? You shouldn't touch skin stuff with your bare naked hands. And washing your hands doesn't necessarily do it. There's a paper in there that looks at that. This, you know, it's an ICU paper about spreading infection. Washing your hands doesn't do it. You know why? You know how long you're supposed to wash your hands to go ahead and eradicate oogies on your hands? 15 to 30 seconds. You know what our average time is when we wash our hands? 7 from wet to dry. Okay, we don't do it. So the better thing to do is actually this, I borrowed this gal's yesterday, is get your little bottle of ethyl alcohol squirty stuff, you know, your little lovely Purell, use it. I had some lady stop me in the restroom yesterday. She was really mad because I didn't wash my hands when I left the, you know, stall. I took my bottle out. I said, this is better. So use it. That's actually much better. Has a 98% eradication rate of bugs on your skin. Do not touch yourself if you've touched a patient. Go right to the sink, wash like crazy, use that Purell, and you'll eradicate this stuff. There were 12 residents at USC who got this. 12 residents in the emergency department at USC walked around with MRSA. Okay, they got it. They had bug furuncles, the whole thing. So you can get this, so be careful.